for other doctors on a Thursday. Although, admittedly, I do believe I missed last week because it was half term and I was away. But back now. So hope Corinne's here. Hello, Corinne. Good to see you. Hope everyone's well. I've got a filter which I put on Instagram, which I feel that I should take off. And you would think, oh, that was easy. Loving the summer vibes. Yeah, that was my sunglasses there. Right. Okay. What we got? We've got some questions, which I'm going to do my level best to answer. If anyone has got their own question, then they can give it a go and 212 and ask me directly. So this is a question that says, I had a revision BBA. BBA is bilateral breast augmentation, for those of you who don't know. So basically breast augmentation. I had a revision breast augmentation around 2016. The left implant was a disaster and had to be replaced a year later. Recently, I have had soreness at upper side of implant below it, armpit, and slight reddening. It feels like the edge of the implant is sticking in tissues internally. Could it cause infection after all this time? So, well, simple answer to the question, could it cause infection after all this time, is yes. You can get infection even, what's that, 2016? What's that? That's like 7 years ago. So you can get late infection. It's rare to have late infection. But I don't necessarily think this is a kind of infected implant kind of thing. So you had a revision, you had the left implant was a disaster, had to be replaced. So you've already got a lot of scar tissue on the left, and now you're getting soreness at the upper side of the armpit, below the armpit, slight reddening. I mean, yes, the reddening is suggestive of infection, and whenever you've got implants in, we are very wary of infection and very aware of infection. So you need to kind of be high alert, I suppose, about infection, more so when you've got implants in than if you didn't have implants in. So I would say that it's important to raise the thing about an implant, raise the question of infection, and get it checked out. So the bottom line is you need to get it checked out. So go and see your surgeon and get it checked out is the bottom line advice. But I'll try and do better than that because you asked me. First of all, whenever you've got a breast with implants in, you've got to remember there's a breast as well as the implant. So it could be something to do with the breast. Is the first thing. People get pain and infections and soreness in breasts. So it could be the breast rather than the implant. If it feels like the edge of the implant is sticking in, then it might, if you can feel that it's actually around where the implant is, then it will be reasonable to suggest that it is due to the implant. But yeah, it would be rare to get infection 7 years later. I suspect, just my gut feeling is that it's probably something to maybe scar tissue around the implant, maybe a bit of tethering. Doesn't sound anything particularly to worry about, but as I said, redness around a breast implant is something we take very seriously, and I'm sure your surgeon would want to know and just check you out to make sure that there's no signs of infection there. But yeah, doesn't have anything too drastically worrying. But always best to get things checked out, because it's always difficult to say just by what you're reading on a message rather than actually seeing you in real life and examining you in real life. That's really what you need. Why is it so important to have surgery close to home? Patients going abroad for surgery, then having complications. How important is continuity of care? Yeah. I mean, I've got to be honest, we are seeing an increased amount of people who are asking for help having had surgery abroad. And I have to be honest, I do feel bad because I feel sorry for them. But the thing that I always say is that when you're having surgery, when you're trying to choose a surgeon or a clinic or a place to have your treatment, what you've got to realize is that the way it works in plastic surgery is that you only have to pay once. So you only have to pay one fee. It's what's called a fixed price package. It's unusual amongst surgery. A lot of surgery, you kind of pay every time. A lot of surgery is insured. So a lot of the work the hospitals do is insured work. And if it isn't, it might be self-pay, but there's not so much of the self-pay packages. Self-pay packages are very common in plastic surgery, but not so common in other kinds of surgery. So in other kinds of surgery, if you have an issue, if you have a problem, and you go back to theatre, then you have to pay again. If you go back and see the doctor, then you have to pay again. You have to pay every time you see the doctor and every time you have a procedure. It might not be you paying, it might be the insurance company paying, but nevertheless, the facility, the insurance, the hospital and the doctor are getting paid every time that they do something. In plastic surgery, it doesn't work that way. It's what's called a fixed price package. You pay once for the whole package of care. And so that might be one of the reasons there's quite a marked price differential for having surgery in the UK and having surgery abroad, and even within the UK, different prices. So you've got to look at what sort of package of care you're going to look for the aftercare, because we get a lot of people who've recently had surgery abroad and are not happy. They don't feel like they're being looked after, and they want to be looked after. And we don't really have a facility for that. We don't have a facility where you can kind of just have the aftercare. Once you've had the surgery, the onus of the aftercare is on the place where you had the surgery. That's part of the package price. And so you can't really have just the aftercare with me, for instance. You know, if you pay for the surgery, you get the aftercare. And a lot of my time is spent looking after people who I've operated on. And we can't really help people who are getting in touch saying, look, I'm not happy with the results of my surgery. Can you have a look and can you help? I mean, I will help, and you can come on here and I'll answer questions. If you've got questions, I'll answer them, and I will help as much as I can. But I won't kind of take on the aftercare, not least because I wouldn't really, you know, I often say, the people in the office take the calls and what have you, and I often say, like, I wouldn't want another surgeon to be commenting on my patient. You know, if I've got a patient who is recently post-op, you know, ideally you should listen to your surgeon, because there's a lot of stuff which isn't written in stone and a lot of stuff which is opinion, and you don't really want to get another surgeon's opinion which might conflict with your surgeon's opinion. Not that your surgeon's wrong, but it's confusing if one guy says, oh, you need a dressing on that, and another one says, oh, I wouldn't put a dressing on that, get in the shower. It's like, who do you believe? So you're better off, unless it's like wildly crazy what they're saying to you, you're better off really sticking with your original surgeon is the advice. And that is why you've got to look at what sort of facility there is for the aftercare. We find a lot of people seem to have a WhatsApp communication with the surgeons and the clinics. Sometimes when they have a problem, they then get banned from that WhatsApp, and therefore they're left completely adrift without any recourse for help. And these things, from a medical point of view, from my point of view as a surgeon, it's completely unacceptable to ban a patient from a WhatsApp just because they've got a complication. So you know, it's important. So yeah, I mean, so the question is, why is it important to have surgery close to home? Well, few reasons. I think it's always good to have surgery close to home because of, as I say, in terms of the aftercare and looking after you, you've got to look at those things. Also, things like traveling. You know, we've had a patient who got in touch yesterday who had a problem with an implant that got infected and then had to be removed, and then they have to have another implant put in, and they don't want to have the next implant put back in you know, abroad. They want to have it done here, and you've got to think that if you need revision surgery, if you need any other procedures, then you're going to have to go back abroad for those procedures. It's difficult to find a surgeon who will kind of take it on at the sort of halfway mark. And if you do find a surgeon that will take it on the halfway mark, they will charge. And so that's something to be aware of, that you're going to have to pay again. Whereas often if you, you know, if it's a revision from the original procedure, something, you know, often they'll be done at a reduced price, or, you know, often no price if it's a you know, something that's come about from the not like, for instance, the implant removed and put back in. You shouldn't really have to pay for that if your original surgeon does it. So really, yes, it's so important to have continuity of care. It's so important to have good aftercare. And I think it's easy to lose sight of that in the pre-op stages. If you're in the research stage, you might look at the outside and think it all looks good, but you got to think, well, what is my line of communication when I have the post-operative, aftercare? Will I be looked after? Because that is part of what you're paying for. And if you're not paying much, it might be that there's skimpings going on there. There's got to be skimpings going on somewhere. There's no such thing as like best aftercare, best quality, best implants, best operating theatres, best surgeons, and best price. It doesn't all. It's just no such thing. If there was, that would everyone would be doing that. So there's always going to be a compromise somewhere, and it might be that you say, look, I can't afford it, and I'm going to go abroad and all this, or whatever, which is fine, and people do, and lots of people do. So it's not only fine; it is happening quite commonly, but kind of like it's just about perhaps having to accept that if something doesn't go right, then you're going to think, okay, well, I knew that was I knew that the aftercare was going to be an issue, and now I've got to see what I can do. But as I say, you might run into trouble because as a surgeon, it might sound unhelpful, but it's an awful lot easier to kind of get it right first time. I know that's really unhelpful to say to someone who's got a problem. I completely understand that, but I would much rather just do a breast augmentation or whatever, or a tummy tuck or whatever it may be, off the fresh patient, rather than taking on one that they've had the surgery and it's not right and they're not happy and there's issues. That's a lot more difficult to attend to because you've got scar tissue in there, you've got an operation, you might not know exactly what's gone on in it, and it's very difficult. And as I say, personally, I feel bad charging people for it because they're obviously price sensitive because they've chosen perhaps I maybe shouldn't say obviously, there might be other reasons they've chosen it, but often it's a price issue, but not always. But it is difficult taking on patients like that. So I guess the point of what I'm trying to say is just an awareness that what you're paying for is not just the surgery. So if you are comparing one to another, then just bear that in mind in terms of your comparison. Look at how it will run in terms of aftercares, in terms of revisions, because that will go into the value equation of what you're going to be paying for. If the Brazilian butt lift is so dangerous, why are Instagram models having this procedure? Good point. Take your point. Well, first of all, are they? I mean, it was back in the. Are they still doing it? They probably are. Yeah, I mean, I'm not deep into the Brazilian butt lift world. I never did butt lifts, and I never got into the butt lift. Although there was a time when it was very popular, and everyone was saying, "Oh, I've got to do butt lifts," and all this. I never got into it, so I am not putting myself out there as an expert at butt lifts. So, Exhibit A. Exhibit B, there was a thing where the BARP said it's very dangerous. We shouldn't be doing it. We should be doing it in terms of a, what's the word, like trial thing, and because a lot of people have died, etc. But there were a lot of people who were saying it doesn't have to be dangerous and that you can do it safely. So I think the point is that, like any procedure, I mean, any procedure has risks. And I think what the point is, not so much that everyone having a butt lift dies, otherwise it wouldn't be great. So there's a lot of people out there having the surgery who have a good result and are very happy. And I guess this is where the Instagram models come in, because there's a lot of people who are very, very happy with the procedure and have got no problems whatsoever, and it's been great. So that's why there's a lot of people out there having it. But there is a group of people who have had problems, and so the people who do it regularly, as I say, not me, but the people who do it regularly would say that it is something that needs to be done in a certain way, and there's a way you can do it to make it safer. It's something that can be done, but but safely. I think that the BARPs and what have you are coming round to it. They've got guidelines in, and now they're saying it can be done safely, and there are specific techniques you can use to make it safer. So I suspect it will probably come back if it hasn't come back already. But with any procedure, it doesn't matter how risky or dangerous it is. There's always going to be people who are okay. I don't think any procedure's got 100%. Not even Russian roulette's got 100% mortality. So there's always a chance you're going to get people who have got a good result. So I think that's why there are still quite a lot of people out there who've had nice results, because it's not a 100% problems, but it was a higher risk of problems, which is why they flagged it up and started to look into it. Do we offer surgery for lip alterations? No, we don't. Not sure why they put this on here. They know that, but I guess they put this on here so that I can communicate to the world. No, we don't. We don't really do facial aesthetics. I mean, we do moles and cysts, but we don't do facial aesthetics. So not sure what lip alterations would be, lip lift, something like that. But no, we don't. Stick to breast and body is the main thing, and moles, cysts, lumps, bumps is the mainstay of the work. After having a gastric bypass, do I need to wait a certain time before having a breast reduction? Yes, you do. So you should work with your bariatric team, the people who did your bypass. So work with them and see and make sure they're comfortable with you undergoing surgery. But it takes some period of time for your weight to stabilize, also for your body metabolism and electrolytes and what have you to stabilize after the gastric bypass. So you need to have things on a stable footing. And certainly if you are losing weight, or if your weight is changing in any way, really, you don't want to have a breast reduction or any body contouring surgery. So you want to have it once your weight has stabilized. Once you've lost the weight and your weight is stable, you really need to have your weight stable. Personally, I don't have a kind of set time frame for it, but I would say you've got to be true to yourself, because if you put on or if you lose weight after the surgery, it can have an unpredictable effect on your breasts, on the shape, on the size. So really need to be stable. 3 to 6 months, I would say, is reasonable. Sometimes when I was in the NHS, I think they said you had to have it stable for 2 years, sort of documented BMI stable for 2 years, which is obviously quite a big deal to ask someone. But I think 3 to 6 months, I think is reasonable to have a stable weight. So first of all, you got to lose the weight, and then you've got to stabilize with that weight loss before having a breast reduction. Are there any side effects to having a mole removed? Side effects. Now, side effects is a bit of a kind of like a layman's term, medical. Side effects kind of suggests to me like a drug or a tablet or something that has a adverse effect. Like can cause a rash or can cause your wee to go green or something. But so side effects of a mole removal. I mean, I guess I'd answer that question by saying complications of a mole removal. So obviously a scar. Is that a side effect, a scar? I guess it is. It's a side effect. It's an effect on the side. So yeah, okay. Well, in that case, yes, scar's a side effect. What else? Depends on how you remove it. If you remove it by shave excision, you could get a dent or a bump. If you do too much or do too little. If it's a big mole, it could pull. If it's around the eyelid, it can pull your eyelid down. Could be tight if it's sort of like over a joint. Could be tight. I mean, to be honest with you, I'll be honest. When I do a mole removal, a sort of standard mole that's not in some funny area or difficult, particularly large, I normally list the risks of bleeding, infection, and scar. And I say scar's not a risk. Scars are definite. Scars are definite. Bleeding and infection are risks. So I guess those are the main side effects: the scar, bleeding, and infection, and the bleeding and infection are short-term problems. So yeah, scar is the main side effect. I want a breast reduction, but I still breastfeed every now and again. What would be your advice for having surgery? Can you breastfeed every now and again? Anyway, well, yeah, okay. Well, my advice would not to have a breast reduction. That's my advice there, because for 2 reasons. First of all, like you say, you want to be able to breastfeed, and there's a chance you might not be able to breastfeed after having a breast reduction. you might be able to breastfeed. So I'm not saying you wouldn't. I'm not saying it's 100%, but there's a chance you might not be able to breastfeed after having a breast reduction. That's the first thing, and probably the most important thing for you. So in that respect, wait until you finish breastfeeding. But the other thing is, if you're breastfeeding, your breasts become engorged with milk and they become bigger. And then when you stop breastfeeding, they become smaller and they can droop. So the shape can change. And so we really want that to happen before doing the breast reduction. You don't really want to be doing a breast reduction while you're in that state of swollen breasts, because if you have a breast reduction and the breast then get less swollen and droop, then you might not be happy, because part of a breast reduction is a lift. And when we do a lift, we make it as tight as we can. So if we make it as tight as we can, and then you go and stop breastfeeding and it's no longer tight and it droops again, you're probably not going to be happy. So for 2 reasons, finish breastfeeding before having a breast reduction would be my advice. Does a mini tummy tuck repair diastasis recti? Okay, so does a mini tummy tuck repair diastasis recti? I'm going to go easy on this answer, and if I go easy, I'm going to say no, it doesn't. That's the easy answer. Diastasis recti is the rectus muscle, the 2 muscles, which are your 6-pack muscles, which are actually vertically orientated on either side of your belly button. It's just like the 6-pack. But they're 2 muscles that are side by side by your belly button. And when you have a pregnancy or when you put on weight, those muscles can become apart. And that's called diastasis recti, or divarification of the recti. And when we do a tummy tuck, we routinely repair that. Now, the problem with a mini tummy tuck is you don't tend to go above the belly button. So I'll give you the short answer is that you don't go above the belly button stays where it is. So the dissection goes up to the belly button. And so you can't really repair a significant diastasis recti, because you really have to get up to the xiphisternum, up to the rib cage, up here, before you can properly repair those muscles, because the muscles go all the way from your pubic bone up to your rib cage. So you can't get that high when you're doing a mini tummy tuck. So that's the short and simple answer. The other answer is that maybe, because if you float the belly button, which means transect the stalk of the belly button, so the belly button's no longer attached to anything down deep, then you could maybe tunnel up and get a bit higher and try and repair a diastasis recti. It's very hard though. And there's a risk that belly button could get pulled down even more, and you wouldn't be able to have a tummy tuck in the future, or at least if you did, that belly button would not survive if you had a tummy tuck a full tummy tuck in the future. So you would have to have a belly button reconstructed if you did go on to have a full tummy tuck. It's not common to have a mini to a full, but it's just something to be aware. If they did float the belly button and try and get above the belly button to repair a diastasis, then that would impact your ability to have a full tummy tuck in the future. And as I say, it's quite difficult doing it through a mini tummy tuck incision, because it's much smaller, lower in the abdomen than a full tummy tuck, which exposes the whole abdomen, the whole rectus muscles, so you can repair them relatively easily. They're right in front of you, but it is quite hard to get up there when you're doing a mini tummy tuck if you're trying to do it through a mini tummy tuck incision. So my personally, I would say no on those grounds. But someone out there will probably say, "Oh, I repair diastasis when I do a mini tummy tuck," which is fine if they're doing that, and that's fine. So if you've got a significant diastasis recti, well, I'd have to see. I was going to say. So I was going to say you should have a full tummy tuck, but some people aren't candidates for a full tummy tuck. But if you've got significant diastasis, you would think the abdomen have been stretched to a degree that you might be able to have a full tummy tuck. Basically, it's a lot easier all round to have a full tummy tuck, because then, as I say, it's an integral part of it. And if you have a mini, then it just becomes a little bit more. Usually, in my experience, people having a mini, you just don't repair the diastasis, and you just and it's usually not a big issue, because again, in my experience, there's a much smaller group of patients who are a candidate for a mini compared to a full. And those people who are candidates for a mini usually just have a bit of a bulge above the pubic area. If they've had a cesarean, it's a little bit of a bulge above the cesarean scar, and a mini will flatten that bulge. but doesn't really do anything to the rest of the abdomen, globally around the abdomen. So it's not quite as extensive in terms of the contouring of the abdomen, but it's also not quite as extensive in terms of the risks and the complications and the scarring. So it's a balance on that one. Blimey. Oh, how to practice with this. So that's the questions for Tuesday, the 6th of June, 2023. So this guy's going to be back next Tuesday, which will be 6 plus 7, which is 2, 6 to 12, 13. The 13th of June, Tuesday, the 13th of June, 7 o'clock, answering your questions. So if you've got a question, call me, message me, or email, or get on the online chat on the website, or WhatsApp. You can WhatsApp. I'm hoping you can WhatsApp on Facebook. There's a button you can press on Facebook. You can WhatsApp. Or you can just direct message me on Facebook or Instagram or YouTube or whatever. But anyway, whatever. Just get in touch if you've got any questions. Or just come on 7 o'clock next Tuesday and ask me. Have I missed any of it? There's been people here, but loving the summer vibes. That was it, was it? Yeah, all right. Fair enough. Oh, goodness me. There was some questions, wasn't there? There was some questions. Yes, there was. Yeah, you know what? I often forget to look at the questions on Instagram. But I did look at them today because someone has asked a question on the button on the post that we put. Oh, I hope I can get it on my computer. Can you get your notifications? That's it. Here we go. Oh, wait, it's not there. Messages. It's there. Oh, there was something about breast reduction. Definitely there. Oh, is it because it's on the... What was it now? Okay, what's that? Corin, thank you, JJ. It's an intense one. I think you need a lie down. I do need a lie down. I do need a lie down. I know. If I was right. Where are those bits when people click on the button on Instagram? Where are they? Are they? I'm going to press some buttons here. No requests. Invite to join. No. Oh, yeah. Here we go. Questions from stories. Is it true? What? Well, there's 3. Is it true? Well, that's good, isn't it? I hope I'm still on. Am I still on? Is it? I'm going to close this. All right. Is it true it takes 7 to 9 months for dual plane to settle? Yes, it is true. So dual plane is referring to breast implants, a type of breast way that you can do breast implants. And it's under the muscle, basically. And I've got to be honest with you, it doesn't matter. Forget dual plane. I mean, dual plane does, or under the muscle does take longer to settle than on top of the muscle, for sure. But they both take quite a long time. So I would say 7 to 9 months for on top of the muscle as well. I don't think dual plane necessarily takes like a month or longer or whatever. I think they both take a long time. And I normally, and to be honest, I normally say 6, 12, or 18 months to settle. But so these are all just figures we make up. We don't know. We haven't got anything in. But 7 to 9 sounds reasonable. Yeah, that is true. Next question, can you breastfeed after having a reduction and uplift? Yes, so a reduction and uplift, the same operation. So a reduction just makes them smaller. A lift is the lift part of it, and an uplift is an integral part of a reduction. And the answer to the question is maybe. You have to move the nipple when you're doing an uplift and a reduction. And it's more of an issue with a reduction than an uplift. So you're more likely to be able to breastfeed after an uplift than you would be after a reduction, because with a reduction, you're isolating some of the tissue around the nipple. But you might be able to breastfeed, but you might not. So if it's very important to you to be able to breastfeed, then you should wait until you've finished your family. And there is a reason to wait till you've finished your family anyway, because if you are going to have children and breastfeed, then that can affect the size and shape of your breast. So if you just had a breast reduction, that might be annoying if you spent a lot of money on a breast reduction and then you have children, and then they get bigger or smaller or droopier. So yeah, if it's important to you, and if you are definitely going to have children, it's probably best to wait. But it's something to weigh up in the pros and cons as to when to have surgery. It might, it's not written in stone. You can have surgery and then go on and try and breastfeed later if it's not, massively important to you. You could say, look, I'm going to try, because as I say, you might be able to breastfeed after a reduction, but you might not. I'd like an areola reduction, but want to breastfeed in the future. Would the operation prevent that? No, an areola reduction wouldn't. So an areola reduction is different to a breast reduction or a breast lift. So a breast reduction and lift, you're actually physically moving the areola and isolating the areola. Whilst you do kind of isolate the skin of an areola when you do a areola reduction, you don't go down deep in the same way that you do with a lift or a reduction. So you're not interrupting the milk ducts with an areola reduction. So breastfeeding should be fine with an areola reduction. One thing I would say is that some people can't breastfeed. So as long as you can breastfeed now, you should be able to breastfeed afterwards, after an areola reduction. But with a breast lift or a breast reduction, there might be an interruption in the ability to breastfeed. So areola reduction is absolutely fine to breastfeed, but I would say similar sort of thing really. If you have an areola reduction and you're saying you're going to breastfeed in the future, basically the areola is just a part of the skin of the breast, and if you breastfeed in the future, your breasts will likely get bigger, and then that stretches the skin, and that can stretch the areola. So that's something to consider if you're having an areola reduction, that your areola might stretch if you went on to have children and breastfeed afterwards. But in terms of your ability to breastfeed, that should be absolutely fine. It shouldn't affect your ability to breastfeed. Assuming you can breastfeed now, you should be able to breastfeed after your areola reduction. So those were on the sticker. So thank you. That's the sticker's paid off. Picture of the garden on the sticker there. So I hope you like that. Credit to Amy for that photo. So yeah. So well, yeah, that has been I got to go and have a lie down now, I think. So I will be back on the, whatever I did say earlier, the 13th, is it, of June, which is next Tuesday, whenever next Tuesday is. And very much look forward to seeing you then. In the meantime, enjoy the sunshine. Is it sunny? No, overcast. Enjoy the overcastness, and take care of yourself, and shine brightly. End the stream. And Facebook, yeah, love you big time.